once it allows me to see whether it is going or not. It's saying it's live. You just have to make sure that it is live before we start speaking. Right. I think it is. Right. So for some reason... Let's go. Right, here we go. So hopefully everything's working, because when I just tried to edit it before, it obviously didn't put me onto the right stream. So this one isn't going to be too long. It is mainly going to be just me going through a bit on B12, going through the overview of it. It is probably the most common thing that we discuss within healthcare, and a lot of people are concerned about. So I thought I'll do a quick video on that, and then if anyone is watching live, by all means, I will answer any questions towards the end of it. Pardon me. I've still got a cold, so bear with me if I am coughing and sneezing. And the reason this live is a bit later is because, being a bank holiday, we had a bit of a family meal and ended up watching some old holiday videos and photos. So anyway, like I said, let's get into it. So B12. The reason I picked B12 was, like I said, a lot of people, when they feel tired, it's one of the first things that they go to. But in reality, a lot of people tend to have a normal B12 level, and there are a lot of people who are giving out injections, they're giving out tablets for B12, even though they do not know they have a deficiency. So, like with anything that I can see, there's a lot of questions. I will go through all these questions later on. So, as with any vitamin or mineral deficiency, you should always make sure you actually have that deficiency before you start treating it. So you can't just go off symptoms, because being tired all the time, yes, it can be a sign of B12 deficiency. It could also be a sign of vitamin D. Iron deficiency, it could be blood loss, it could be respiratory conditions, cardio conditions. So that there are so many things that are linked to non-specific symptoms. So that is the last thing I would do, is pick up any sort of supplement or medication without knowing whether I truly have a B12 deficiency. So the first thing is, if you live within the UK, for example, how do you get access to knowing your B12 levels? And it normally comes down to whether you have any symptoms. And the next thing is whether you have any risk factors. So that's the first bit of screening that we look at before we consider whether you need to then go on to have a B12 level. Obviously, there are ways in which you can bypass this. So you could have symptoms with no risk factors, but we could think, well, actually, if B12 deficiency is present on this patient, is that going to lead to more complications down the line if we don't just do a mere B12 level, which isn't expensive. It's very easy to do. So why not do it? So, like I said, you need to have symptoms and risk factors for the majority of people to get tested. So what are symptoms? So tiredness is probably one of the biggest things when you think of B12 deficiency. And the reason being, and this is a very simplified overview, is when you have a red blood cell, it's a certain size. So if you want to look into it, if you ever get a full blood count, you will get something called your mean corpuscular volume. And when you've had B12 deficiency, the red blood cell basically doesn't go down to a smaller size. So this tends to be higher. And when it's higher, because it's not the exact size it needs to be, it then reduces the amount of oxygen, or the efficiency of oxygen, that the red blood cells can carry, which is then why you will generally lead to a lot of tiredness, basically. One of the other things that comes up is a lack of balance. I'm actually going to come up with an easy way to do it. So how would I? What is the best way to... tiredness. I can't even come up with a word beginning with B. So tiredness is one symptom. The next one is balance. So B12 is present in a lot of neurological and nervous system development. So if you've got a lack of balance, then there's a good chance that you could have a B12 deficiency. So that is something that you should always get looked at. Another thing is your tongue. So the fancy word for this is glossitis. I actually never know whether I say this properly. Glossitis. So basically anything with itis on the end is inflammation of this. So inflammation of your tongue. And other things that you could have are, like I just said then, if you have a full blood count, you can have inadequate volume. So you can have anemias with mean corpuscular volume. And then they're the main ones. They're the main symptoms that I would look at. And that's not really a symptom. That's normally once you've had screening. So if you've got inflammation of your tongue, you have poor balance. If you've got cognitive issues, so if you feel like your memory, again, it's so non-specific. Cognitive issues could be due to a urine infection. It could be due to early onset dementia. There's so many things that it could be, but these are all things that you need to weigh up. So balance is one of them, and then tiredness. But this one here, tiredness, is probably the biggest thing. If you ever see me looking off to this direction, by the way, it is also to look at the questions that are coming in, if there's any comments. I can see there are quite a lot of comments, so by all means, I will go through as many as I can at the very end. So these are the main symptoms that you will have. So if you have one of these, and then we go, actually, there's a good chance that they have a high risk of having B12 deficiency. So the biggest risks usually are due to diet. You've got autoimmune. They're the two main ones that I would look into. So there is actually a lot of things. And then the other one that you've got are drugs. When I mean drugs, I usually mean medication. So with diet, a lot of people who have a lot of B12 deficiencies tend to be vegan. And that is because not all, but the majority of B12 comes from animal sources. So you've got beef, red meats, you've got yolk in the eggs, you have, top of my head now, trying to think of quite a few things with them in. It's mainly, and then you've got fish, so you've got mackerel, salmon. So a shellfish is a big one. So it's mainly animal sources. When it comes to vegan sources, and I'm thinking about it from a natural point of view, you have certain types of mushrooms, so shiitake, again, if I pronounce that correctly. And then you've got tempeh, yeah. I think that's the best way to pronounce it. They're the main ways you are going to get it. In most vegans, you will find them having supplementation, or they will have foods such as certain milk products or cereals that have been fortified. And that basically means where they have had added B12 into it to make it nutritionally complete for that person. Now, autoimmune conditions, why is this a risk factor? So you can think of stuff even such as the thyroid. Obviously, you've got IBD. You have, technically diabetes could potentially fall under that if it's type 1. So they're the reasons. And that is because when you have the ability to destroy certain cells in your body, then you can have ongoing inflammation, which is not good for absorption, but also you can reduce the active absorption within your bowel. Drugs, main ones that come to mind, you've got PPIs, which are your omeprazole, lansoprazole, so that stands for proton pump inhibitors. You have metformin, and then you have drugs such as colchicine, and I actually think there are many others such as pregabalin. There are a lot of drugs, and they interfere by just reducing the amount of active B12 that we can absorb. One thing that I've missed is surgery. So a lot of patients who have any gastrointestinal surgery, this could be a gastric sleeve, it could be a gastric bypass, could be all these things. And that is because of how B12 is absorbed. And I think this is something I'm going to run over before I go into levels and what you should be looking at before I go into the questions, because this is sort of more influential towards how you should go about B12 deficiency. So B12, once it comes into your diet, goes into your stomach, it meets a lot of stomach acid within the stomach, which helps dissolve it, break it up a bit. And then once it goes into your small intestine, it gets absorbed. I think from memory, it's towards the latter end of your intestine. However, for B12 to be absorbed across the intestine into your blood, we need it to be paired with something called intrinsic factor. And this is a protein which allows the whole configuration to be absorbed. So if you have a reduction in intrinsic factor, you will have a decrease in B12 absorption. And when you have gastric surgery, you reduce the amount of intrinsic factor. And if you have any other surgeries across here, obviously you are impeding the absorption across this membrane, which is why you can see a lot of patients who undergo these procedures have long-term supplementation. Now, when it comes to supplements, how do we supplement these patients? The most common way is through an injection. So I don't even know why I'm drawing an injection here. Through an injection, and depending on why you've been started on B12 deficiency treatment will determine the dosing that you go through. So usually once you've had a bit of a loading course, you will then either go on to 3 monthly or 2 monthly. And then this is usually given intramuscularly, so it's normally given into your shoulder. And that also bypasses all your intestinal system and allows you to absorb the most amount of B12 that you possibly can. When it comes to ongoing monitoring, we tend to not really do it because B12 is considered a very safe vitamin, even at high levels. But I always think it's always best to have a look at what level you've got just on an ongoing basis. It's always best to know what you are doing. And that comes to the levels that you should be looking out for before I go into the questions. So, pardon me. When you get your results, you will get, depending on where the lab is, you can get a set of different results really. So I would class anything less than 180 nanograms per litre. So anything less than that as B12 deficient. Again, everything that I say in this is for information and educational purposes only. It is not medical advice. So do not act upon this without speaking to a medical professional that looks after you. But less than 180, I would class as B12 deficient. And then anything above 350, pretty sure it's nanograms per litre, but anything above that, I would sort of class that as adequate levels of B12. And when I'm talking about these levels, this is to do with your total B12 levels. There are other tests that we can do, which I'll come on to because I actually wasn't aware of some of the testing. But once it's less than that, it's deficient. Once it's greater than that, it's normally enough. If you are within this grey zone, then you could have B12 deficiency, you could not have it. It's all dependent upon your symptoms and whether you would respond to treatment. And that's the biggest thing. We used to have a saying when we were going through training, basically, that you treat the patient, not the level. So 180 for someone could actually have no symptoms, whereas 340 for someone else could have a lot of symptoms. So you've always got to treat the level, treat the patient, not the level. And that is just a general rule of thumb. So just before I go into the questions, I think it's a very, very quick tour. And then I will go into, so I've talked about how you manage it from a usual point of view. If you have a level which is on, it's not too low, but it's usually due to the fact that you've got a lack of things in your diet. By all means, if you have the dietary options that I've just said before in terms of a lot of animal products, whilst balancing all your saturated fats and energy intake, you will usually replete that enough. If you are vegan and you are struggling, then you can go and buy a lot of over-the-counter supplements. A lot of them, the most common one that I can think of, so cyanocobalamin, that's an oral one. Usually comes in about 50 microgram tablets. It's usually about once a day. You can have that 1 to 3 times a day. And then the one in the injection is called hydroxyl, just for completeness, cobalamin. That's usually 1 milligram every 2 to 3 months. So that's the usual treatment. Now, going back to before I come on to doing this live, I just had a quick look at what were the guidelines looking like, because when it comes to B12 and a lot of things in medicine, you don't really tend to change your practice over a couple of years. It normally takes maybe decades for something to come in. However, B12 has been one where it has actually changed. So before I discussed total B12, and that was the level, or they were the levels that I was shown before. You can also get active B12. I will be honest, I have never seen that within the GP surgeries. You can also get one called MMA, I believe, and you can also get one called homocysteine. Now, these definitely homocysteine, but I think MMA as well will be done if needed in a hospital. And the reason you would probably opt for these more than these forms are that sometimes you can have a false positive when it comes to B12 tests. It could be that you are on certain medication. So I learned that if you use the nitrous oxide within the recreational drugs, if you want to call it that, the laughing gas, the balloons, then you can basically affect levels of B12. So homocysteine, I believe, is like a good way to measure that. So these are used as we would use a lot of other tests, just to make sure that we are not missing anything untoward. Pardon me. That was a very, very quick whistle stop tour. However, I am going to let me have a quick look. Right. So there are a lot of questions here. So I can just see the latest ones. How are you, B12? Okay, I'll come on to that one. By all means, any questions, you can put them in below. Just drop by to give a little like. It's late night here. Bye bye. Thank you very much. So, as I said, let's go through the many questions. I think this is the best way to go for it. So, the first one is up to 28% of patients with B12 deficiency have neurological symptoms without any changes in their red blood. I'm guessing that was going to say cells. Yes. So, when it comes to blood results, this is where it becomes a bit ambiguous and why you need to take stuff with a pinch of salt. So I said before that B12, if this is a red blood cell, in a normal patient, it would be that size. In someone who's got a B12 deficiency, it may be that size. And that is called something called macrocytic anemia. So that's what it's called, or macrocytosis, whatever term you want to use. Basically the same thing. It means that your red blood cells are high in volume. Now, like I said, this then reduces the ability of that red blood cell to carry oxygen efficiently. Now, if you have someone who has iron deficiency anemia, so that could be a lack of iron in the diet, it could be excessive blood loss, what happens is you get something called microcytic. So obviously you can see where this is going. So you can get something called microcytic anemia. So if you have someone who has low B12 but low iron due to something else, the fact that they're small and they're big, it will actually show up on their MCV as being potentially normal, which, top of my head, I think it's about 80 to 105, give or take. So usually that might be 120. This one might be 70, but when you merge the two together, you get a normal MCV, which is why you can't look at stuff in isolation. So that was a good point. So yeah, you can look into that yourself, microcytic and macrocytic anemias. So they found that neuropsychiatric, like OCD. So there was a thing that I did look into with regards to B12 and mental health. Now, like I've just said before, you can see that B12 is involved in a lot of nerve function. It's involved in many processes throughout the body. So there was a bit of research done into, or research that was trying to delve into whether people who have psychosis and other mental health disorders, whether having a lower B12 will put them at a higher risk. There wasn't any significant outcomes from that. That doesn't mean it doesn't exist, but they just, from that particular study or research that they carried out, there wasn't anything that was overwhelmingly significant. So by the looks of it, it looks like they will be going into it a bit more, but there wasn't anything categoric when it come across that. Stat pairs, the official medical database notes that B12 deficiency leads to impaired concentration. Yes, I agree. B12 deficiency, by the way, is something that is not something to be overlooked. Like I said, you should never blindly have supplementation or take medication without knowing the actual true underlying cause. And the reason I say this is, so for example, there's been a lot of cases where people who get inflammation of the tongue and they go, well, I've heard that's B12 deficiency related, so I'm just going to take B12. So then you go and get a blood test done at the GP surgery or the hospital, and your B12 comes back as normal. So then you've sort of thrown everyone off the track of it potentially being B12 deficiency. And when you have a B12 deficiency, it can lead to demyelination. It can lead to a lot of loss within neurological function. And B12 is something that we take quite seriously, but because of the fact that people just see it as a vitamin, I think it does lose its credibility. So it is something that you need to definitely give a bit more respect to. So B12 deficiency, low B12 specifically mediates the relationship between OCT, poor sleep, be the key. There's no doubt that B12 the is pivotal to a lot of things. And like I said, with the fact that a lot of diets at the moment aren't containing a lot of whole foods, a lot of people's gut when it comes to absorption is greatly reduced. A lot of people are probably under repleting themselves with vitamin B12 and then they're going for maybe supplements or they're doing other things. More people than ever have been on medication. Like I said, the medications such as PPIs, which are your omeprazole, anything that really ends with Zol, I would say. So there for acid, you've got metformin, like I done on the other day. In the UK alone, there's about 5.2 million people who are type 2 diabetic who potentially will be on metformin. You've also got other medications such as pregabalin. You also have medications such as colchicine, which is for gout. So all of these can lead to lower B12 levels. So I don't dispute the fact that a lot of people actually have it. The borderline trap. So this is saying patients between 200 and 300 are often told they are fine, but 28% in this range already have neurological deficits without any blood cell changes. So since research shows that borderline B12 can lead to brain tissue shrinkage, atrophy over time, can we treat this aggressively now to prevent future cognitive decline? Sorry. My speech tonight is not the best because it is quite late. However, I agree, and that is what I said at the very beginning, is that you need to treat the individual, not the level. So I would say a total level of 350 plus is where we would like to be. Anything less than that, I would say is quite low, and you should be looking into why is it low. Is it because you're taking a medication? Is it because you have an autoimmune condition? Is it because you've had gastric surgery? Is it because you just do not have enough from your diet? You need to look into those things first, and then you need to make sure that you are correcting it, because for the body to be optimal, everything needs to be where it should be, and that is including vitamins and minerals, that's exercise. There's all these things that come together to make the body an efficient process. So definitely, if your level is below 350, you should look into why is it that low. But I do agree, the longer that you have it, and this is the thing with a lot of medicine, health, and other things, is that, how would I put it now? If you get your bloods checked today and your B12 is 380, and you think, wonderful, all good, you could potentially have your bloods checked again in 2 weeks' time, and it could be 300, which obviously isn't ideal. But we obviously just take a value like that as a snapshot and say, you know what, it's good. You probably don't need to get that tested again. Come back if you have any symptoms. However, it could drop to this the next week, and you may not have any symptoms, and then you're having more time out of the correct range. And I always try to tell people that if you think of this as time going this way and your, how would I put it, exposure, that'll become apparent when I explain it that way. You want to look at the area under the curve. So if you were looking at B12, let's say this is what you class as a normal level. If you go up and then go down and spend the rest of your life like that until you pass away, this area under the curve will be lower than obviously if you were higher above it until you passed away. And I always tell people you should always look at the area under the curve and not just a snapshot, because it's like me saying now, after payday, everyone needs to send me a screenshot of their bank accounts, and I'm going to judge your wealth based on your bank account with that snapshot. Obviously, everyone's going to be classed as wealthy or better off than what they normally are. However, I should be looking at what does their money look like over the month after they've paid their bills and after they've done a bit of socializing and spent a lot of money. That is what's going to give me a true representation of their wealth along with assets. So that is the best way to look into it. Now, should I be screened for low stomach acid? If my stomach isn't enough, I might not be able to pull B12 out of the food I eat. I mean, very rarely have I ever seen anyone get screened for stomach acid. In the overwhelming majority of people, you will normally have a higher stomach acid production than what we should be having, unless you are taking medication such as anything ending in azole, so omeprazole, lansoprazole, pantoprazole. If you are taking stuff such as famotidine, cimetidine, all these things that suppress stomach acid, then by all means, definitely look into that. Even antacids such as Gaviscon. The only other time I would really look into stomach acid is if you've had any gastric surgery of any sort, because other than that, you're normally going to be overproducing acid because of the types of diet that we hold within modern society. So I wouldn't really look into it in that sense. One thing that you can look into, which I will write down for you now, is yes, stomach acid is required in the process to absorb B12, like you've just said, and that is why people who take their medications tend to have lower levels. But there is something, like I said before, called, I'll abbreviate it, IF, which is intrinsic factor. Now, it's late at night. I can't think of what cells produce it. I think it is the parietal cells or maybe the chief cells. I can't think of the stomach or gastric mucosa. Either way, without this is essentially a chaperone. And without this chaperone, the B12 cannot come into your body. So what we do in patients who have no probable cause for having a low B12, they've got a good diet, they've had no gastric surgery, they are not on medication, we can have a look for something called intrinsic factor antibodies. And antibodies is probably a term that everyone is familiar with, especially post-COVID. You can think of them as these little Y sticks, and they go after little toxins in your body. And if your body obviously turns on itself, it will recognize certain parts of your body as a foreign substance and will attack it. So if your body turns on intrinsic factor, then you're going to have lower levels, which is going to lead to a decrease in B12 absorption. So that is one blood test that you can get done for your GP surgery. However, that is only if you were to be suspected of having abnormally low B12. Since B12 is essential for myelin formation, which it is, could long-term low levels be causing short circuits that manifest as OCD? Anything that is affecting neurological development can lead to a combination of disorders. OCD, potentially one of them. Like I said, you should never leave things on the table. If you can correct something, by all means do that. And that is with every aspect of health. And B12, like I said, is no different to that. Should we check my folate and vitamin D levels as deficiencies in these overlap with vitamin B12? Yes. So in the UK anyway, when you get your B12 checked, or you were to get your folate checked, you will normally get your B12 first. And the reason is that you just said then, so you've got vitamin B9, which is folate, and then you've got B12, which is cobalamin. So if you have a low folate or a low B12, they all lead to basically the same thing, larger red blood cells, which leads to a higher mean corpuscular volume, macrocytosis or macrocytic anemia. However, this was one thing we were always taught in hospital, is that if you check your folate and it comes back as low, I think of my labs are less than 4.5. So if it comes back as low, before you treat folate deficiency, you need to check your vitamin B12, because there could be an underlying vitamin B12 deficiency. And as we know, if you do not treat that, you can lead to demyelination and you can have a lot of bad outcomes from that. Vitamin B12, again, always got to check. More than not, there will be a great deficiency in that, because we don't have enough sunlight within the Northern Hemisphere for at least 6 months of the year. And we don't really treat the levels to what I think we should be. In the NHS, we say if it's greater than 50, then it's all good. When in reality, in my opinion, we should be going towards the 100 to 125. And you will find a lot of patients have less than 50 and they need to go on supplementation. So definitely get them checked, get them corrected in the correct order, and you will obviously have a better outcome when it comes to health. So, does my history of borderline B12 explain why I feel mentally drained? Could be, but until you get a full level, and that's of total B12, active B12, and go through all them things, then do not treat yourself. And that is obviously a conversation you will have with your doctor, prescriber, whoever that is. Can low B12 cause, let me have, executive dysfunction? Potentially. Again, anything that's involved within that pathway has got a big chance of causing it. And you're not really going to have large amounts of evidence at this moment in time because of the way medical research happens. You've got to do prospective cohort studies, and you'll probably find a lot of data within the next 5 years because ADHD over the past few years has become more prevalent within society. More people are holding clinics. So I feel like there's going to be a clinical interest to do retrospective studies on that. So let me have a quick look. Research shows that for many, a level above 500 is often needed to resolve. Can we retest in 3 months to see if supplementation is actually improving my blood levels and mental clarity? Retesting after B12, like I said, is not something that is normally done. However, I always advise retesting after B12, folate, and vitamin D. Any deficiency, I would always advise retesting because you don't know where you sit and you don't know your response to certain things. So, definitely, if I was hosting a clinic and a GP surgery, I would be requesting a B12 level again once you've had a few months of treatment to make sure that that is actually working for you. So, yes, I don't see why not. If not, they would have to have a good reason, in my opinion. Let's have a quick look. So, let me have a quick look at this one. Given my... Are the pins and needles I feel related to B12, and is there a risk of becoming permanent? Pins and needles are one of the symptoms of low B12. However, it's not the only thing. It can be due to loads of things, and I'm not going to say too many things because they could come across as scary, but you could have nerve damage, you could have carpal tunnel syndrome, you could just have inadequate blood supply. There are a lot of things that could be present, but B12 deficiency is definitely one of the things. You can't rule that out. For years, would B12 injections be more effective than pills because my B12 levels have been borderline for years? At the end of the day, the injection is the best because when you take anything through, pretend this is the oral route, it goes into your stomach, goes into your intestine, and then once that's absorbed, it goes through something called the hepatic portal vein. And this is why the liver is so special because it gets two blood supplies. And once everything that comes out of your intestine is first screened by the liver. Once it's screened by the liver, it then is allowed to go into general circulation and then get circulated to where it needs to be. If you give it into the muscle, you bypass all of this, you bypass the liver, and it goes into general circulation. So the gold standard for absorption is intravenous because it goes directly into the vein. The next thing basically is intramuscular because when it goes into the muscle, it bypasses all the liver. However, the absorption of it can be impaired depending on your musculature and blood supply and a few other issues. So injections are always the gold standard. However, if you do not have enough B12 in your diet, simply increasing that naturally through your diet or supplementation is potentially going to be a good thing for you. However, like I said, not medical advice. Always consult someone first before you go about these things because you need to ensure that everything that you're doing is being tracked, and that is when you get the best returns from that. Let me have a quick look here. So, should we check intrinsic factor? Yeah, I always go for it anyway. So yeah, definitely get it checked. Why not? I don't think there's any reason not to have it, really. Obviously funding, but I normally get it checked if someone's got low levels and there's no probable cause. Is it possible I have an absorption issue like pernicious anemia rather than just a dietary deficiency? Again, potentially. Depends on if you've got any damage to your gastric or gastrointestinal system. And you would know that through intrinsic factor. That is basically how you assess pernicious anemia, if I can get my words out. Can we test MMA and homocysteine? Usually it's secondary care, so that is hospital or specialist clinics. In your GP surgery, you are just normally going to get total B12. I've never seen active B12 even done, so that is the one that would be more available within a GP surgery. But definitely you can get that checked within a hospital or specialist clinic. Since B12 is needed to make serotonin and dopamine, could my levels be making my current mental health conditions less effective? Potentially. Theoretically, it makes sense. And my advice would be, obviously, like I keep saying, get everything optimized before you look at any more solutions. Studies link low B12 to increased OCD. There's multiple PubMeds, NHS, and other well-known websites that seriously link B12 to increased mental health disorders. But my doctor thinks it's just a vitamin and it's not possible. Yes, a lot like I said before, because it's so available everywhere, I think that's what removes its importance away from things. And that's the issue with a lot of things. So B12, folate, thiamine, all these things, if you have low levels or high sometimes, it can lead to potentially complex outcomes. And regardless of if it's a vitamin or not, you need to get it checked out. So I would disregard that notion that it's not important, because it is. There's no two ways about it. So let me have a quick look at this. 180 to 350 is lab normal, but under 500 is well known to cause mental health symptoms. Yes, but again, I think 350 is a good level. That is where the statistics are showing that a lot of people have good outcomes above 350, which is higher than a lot of lab values, because in how would I put it? In a lot of labs across the UK, there are ones that I work in Manchester where they say 160, others are saying about 185. So to have 350 as the low cutoff for me is giving you a large safety net. But I can see what you're saying. So let me have a look. How are you, B12? I don't know what that means. Japan and other countries think under 500 is borderline grey area because there are many studies shown to say nice guideline. Yeah, updated in March. My man. That's the thing. So when you've got certain specialities, so for example, I'm going to pluck out one top of my head is ferritin. So if you ever get your iron done, if you've ever had low iron or iron deficiency anemia ever within the past, then you will get something called iron studies. And ferritin is one of the things that we get checked. I don't know why I can't spell anything this evening. Most clinics will say anything less than about 15 is low. Some people say 30, but the British Society of Gastroenterologists say less than 50. That is my absolute minimum that I go off, because there are so many things that can affect this. And that is what you will find with other things. So where people are looking at it for mental health, they will say, well, actually, we find better outcomes when it's higher. So they will try and instill that into guidance. But to try and get it as a mainstream guidelines where people are saying, well, actually, I'm going to treat it to this level, takes a lot more research, in the sense that if you weren't to have any mental health disorders, is there of great benefit for you having a higher B12 level than 180 or 350? And that's what you've got to bear in mind, is that it's not going to be applicable to everyone. And that is where we try and find the greatest balance with a lot of these things. Just drop by. I've seen that one. Thank you very much. For 10 years, my B12 was under 250, but my doctor has just put me on B12 because it's actually very low. At least it's getting seen to. Highly, I thought you were going to reschedule. I thought I was as well, but like I said, I was going to do it, and I will come on to how YouTube's going to go forward for me in terms of schedules and other things. Doctors see over 200 as lab normal, so B12 deficiency goes unrecognised for years because doctors don't know what they're talking about. Suggests 500 to what, 1500. I think the hardest thing with levels on labs and how it comes through. So obviously, if you think about it, the average GP surgery, I'm going to go off in the UK, has about 5,000 patients. Of that 5,000, on average, you will have, I'm just going to try and do these numbers, you will have at least 3,000 people on repeat medication. And then out of the remaining 2,000, you would normally have at least 500, at least, who have had one or more prescription in the last year. And that could just be as a one-off. Now, potentially you've got, give or take, 3,500 people who would have had a blood test through this GP surgery each year. Of these 3,000, there are some medications that require you to have it at least every 3 months. So let's say you have 10,000, this is very conservative, I think, 10,000 repeat blood tests each year. And then the average blood test probably has about 4 biomarkers. So you could have about 40,000 blood results coming through for one surgery. And when it's coming on, you obviously have the lab values, which I agree should be changed. But medicine takes a bit of time to get that changed. So when something is coming back as 200, for example, and the lab have reported it as normal, then it's not really flagging up for any of the practitioners. The only time that really gets flagged up then is if I do a review and I go through their medication and say, well, actually, you're on metformin. Let's see what your B12 is. Oh, your level's 200. Ideally, we should get that higher. What's your diet like? Oh, it's vegan. I don't have any animal products or don't have any fortified foods. Well, actually, let's put a bit of fortified foods in there. Let's see if your B12 goes higher. And then we look at it that way. But yes, the only way around these mass population issues where levels are coming back as normal is, one, increase the general health of the population, because then normal becomes recalibrated. And the second thing is to just completely change the limits altogether based on updated evidence, because like I said, a lot of things within medicine takes a while to come through. So we've got that, but I agree, there are a few things like that. Should liquid B12 be taken on an empty stomach on meds? No surgery. So let me see. What do you mean B12 on an empty stomach? Liquid B12 is probably going to be a bit different. Now, I've had conflict. I'm actually going to look at this whilst I'm here now. See if, let's see B12 liquid. I'll see if it comes up as anything, if there's any manufacturer guidance on this. Because, let's see, I've actually never really seen B12 liquid. I'm going to go for B12. Anything within liquid formulation normally increases the absorption. I mean, to be honest, I think it would be best on an empty stomach, just because it increases or reduces the chance of chelation. So that's chelation, if you couldn't understand what I've said, because I can't, because the way I'm speaking. Chelation is basically where if you eat something at the same time as something else, you've got the potential of it to join. And if you join it, you then have a bigger molecule which has less chance of being absorbed across the intestine. That's why you need to take some medication at different times of day and on an empty stomach. Let me see what this is saying. So, how and when to take cyanocobalamin, which is a form of B12. You can take them as capsules, spray, and drops. Blah, 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 blah. Is it going to tell me how to take them? Usually should do. If you're taking this, how to take it: swallow with a whole drink of water. Best to take on an empty stomach. Okay, that made a bit of sense. Most things you would take on an empty stomach. The only time that you would take some medication with food is that the medication itself is directly irritant to the stomach lining, so aspirin being one of them. And sometimes food can actually increase the absorption of a certain medication. So there are blood thinners. So rivaroxaban has its absorption increased when you take it with food. So that is something just to bear in mind. But a good question. The way that you can find out whether you should take any medication on a full stomach or not, I mean, if you ever get it prescribed, you will normally get in the UK, I think in the US as well. So you'll get, there's your box of medication, you'll get a label on the back of it, you'll normally get dates, pharmacy stamps, directions here, and then pre-printed is the instructions here, and it'll say take 30 minutes before this or take on a full stomach, and that's how you best know. If you do not have that, then you can have a look at the manufacturer's guidance. So if you type in any medication, you can do this now. So you can type in, let's pick omeprazole. So you can type in omeprazole into Google and type in SPC after it. That stands for Summary of Product Characteristics. And this is basically the guidance that a manufacturer has to legally issue when they've produced a medicinal product. And that will give you a guidance on how to take it, when to be cautioned, what interactions there are, what side effects are being reported through studies. The actual study data comes through a lot of things. It's very comprehensive. There are two forms. There is the patient-facing one, which I would advise to go on to, because the healthcare professional one, you can get lost in it, and it is quite a large document for each one. But a good question. My psychiatrist thinks most cases now of ADHD is actually B12 deficiency. Again, who is anyone to argue until there is a prospective cohort on it and there's a lot of data on it? So it needs to be disproven or proved at this moment in time. It's interesting you bring up ferritin. Is there a specific test that I should ask for? Chronic fatigue, is ferritin often overlooked? Yes. Right. I know it's B12, but let's go through. If you feel tired and you go for a medical review, it will trigger something, and you will see it on your medical notes, and it'll come up as this. It'll come up as TAT, stands for tired all the time. And basically, it will trigger every conceivable blood test. There's a few that you may need to add in that can lead to a lack of energy. So this can be anything from your thyroid, it can be your diabetes, it can be anemia, so full blood count, it can be vitamin D, B12, folate. What else is there that I am missing? It can obviously be inflammation, so they can do CRP. There are so many things that can lead to you being tired all the time that it triggers these massive sets of blood results. And when it comes to ferritin, depending on where you are, so if you go in and you say, I think I've got anemia, I've got chronic fatigue, they will do something called a full blood count. And the usual result that they look for is your hemoglobin. Depending on where you are in the world, women have a lower threshold than men. So the cutoff for women is 120. So anything below that, you would be classed as iron deficient with anemia. And for men, it's 130. Now, the only issue with this is that for you to have iron deficiency anemia, then it is the last sort of presentation. You can have iron deficiency before you come to anemia, because anemia is where you've got a lack of production of the correct blood cells in the body. So it would essentially be the last thing that happens. Before then, you can have iron deficiency without anemia. And the way that you look for iron deficiency are asking for something called iron studies. Now, you will get a lot of blood tests, so you will get iron level, which is okay, not the best. You will get something called a transferrin saturation. You will also get saturation. And these are basically talking about, I've got to sort of add something else in. So when iron goes around the body, it has to be transported around in a taxi, essentially, and that is transferrin. So depending on how much is bound to transferrin or how much is free on the actual transferrin site, will then give you another idea of your iron levels. And then the last one is ferritin, which I will do its own little thing on. And ferritin, the best way to think of ferritin is it is the storage of iron. It has been ferreted away. So ferritin is the storage of iron. Like I said, I would advise, or I would say that anything below 50 is classed as an anemia. Most labs will say anything around the 10, 15, but that's way too low for me, especially within women who obviously are having menstrual cycles in the majority of cases each month. The only thing with ferritin is it tells you how much iron is stored within your body. The other issue that you've got is that if you ever have an infection or an inflammatory response, the body also increases the amount of ferritin we release. So this level here then becomes a bit ambiguous. It could be the fact that you've got active inflammation, or it could be that you've just got a lot stored. And that is why we opt for a higher level, because then it sort of counteracts if you've got high levels of inflammation within the body. But that is why a lot of blood tests as well, you cannot review in isolation. But ferritin is something that I always guide my patients on when it comes to iron treatments, because it's the best way of you knowing your storage level within the body. So yeah, good question. Right, let me have a look. Is there a type of anemia that is hard to diagnose? Yeah, technically, all. I mean, iron deficiency as an anemia is quite easy. B12 can be hard if you have, so that's called macrocytic anemia. If you've got iron deficiency anemia with low B12, your B12 will get missed by one of your blood tests because it will look normal. So that is probably a hard thing to diagnose. Iron deficiency anemia can be hard to diagnose if you've got a lot of inflammation present, like I just said then. And then there's what other anemias that are quite hard to diagnose? A lot of them are actually not too bad. Hematology, once you have any other issues with any potential anemias, you will just go straight to hematology where they can do a lot of advanced testing. And then the good thing with hematology is they actually really look after the patients. They will take over the prescribing, the monitoring, and making sure that patients are well looked after. But it was a good question. I actually answered your question straight after it. So is ferritin, yeah, so I've done that one. I have B12 liquid that I never take a lot. Also, these live streams are pretty sick, very informative. The scrubs. Thank you very much. So I will actually bring this question up here, or bring this point up here. So with the live streams, I've been again. So normally I've been doing 7 o'clock today. I set it back because I had a bit of a family meal. With regards to what's happening going forward, and it sounds like I'm upselling. I'm not, because YouTube's still going to be a place that I'm going to come on to. With YouTube, I would probably do a video like this without the live. If I've got time, I will do a live, but if not, I will just do a B12, common questions, and it'll be maybe 15, 20 minutes of me just doing a quick tour of something, going through commonly asked questions. But when I do this online community, so I'm doing an online community by the end of this month, it'll be on the 29th of May. And what is available in this? So I'm still going to do YouTube, but the only difference is where I've been asking what topics do people want, I will just come onto YouTube, and next week I might do a video on vitamin D deficiency. I might do one on statins causing muscle pain. I don't know. I'll obviously go for things that I think are relevant, but it'll be just something that's led by me doing a video. Whereas on the 29th of May, I am opening this community on WAP, which I've slowly started to introduce. It's a paid online private community. The only difference being I do daily posts in there, and basically the live streams are like this, but it's a dedicated time. So if we agree it's Tuesday at 7 o'clock UK time, it will always be Tuesday, 7 o'clock UK time. It will be dedicated and protected time, and it will be led by whatever the community wants. It's a democracy. So I'll put out what is the overwhelming thing that we want to discuss this week, and someone might say how to make a high protein meal. And if everyone votes for that, that is what we go through. And the other things I post in the community will be things like I've just found out here that you can have 4 other tests for B12. So I'll put that in there. I'll give you the links, the studies, and my breakdown. So if you want to have a quick look, it'll be like a bite-sized piece of information. So that's basically what I'm going to be doing. So But yeah, with B12, like I just said, for that one with the liquid, is that just go and get your levels checked if you have the ability. Don't take it blindly. And if your levels are low, then make sure that you are getting the correct therapy and you are being followed up, because if you have a deficiency, what is the reason for that deficiency? That's the thing I always try and advise people to look into. So, says most doctors only ever look at this disease low enough to cause. My doctor says B12 is only a vitamin, but my psychiatrist says that why he is only a doctor because he doesn't have a clue about mental health. Obviously, the wealth of information that we've got now and things that it could be relating to certain conditions, whether that be cardiology, respiratory, mental health. There are so many things that you can't really categorically say. But the one thing I would say is if you have, I always say this on a live stream, that health or good health for a lot of people, as long as it's not genetically driven, is quite easy in the sense that if you have a balanced diet, if you have good levels of exercise, if you have good levels of mindfulness in terms of stress relief, you have good levels of sleep, you will be in the top 10% of any healthy population. So definitely, I don't think it's something that we should overlook with anything, especially if there are any concerns about anything affecting your health. By the way, when is the next stream Q&A? I mean, yeah. So that's what I was just saying then. When Because I've got a bit of traveling and things to do, it may be. Yeah, I will come on to that. So because I've got a bit of traveling and business to do this month, it's not as nailed on. So that's why I'm doing that community. If you are interested within that community, let me know. And I think I put up on this community on anyway. If you go into the bio, there's a link there. That will be there. That will be once a week live stream led by me. Well, led by yous, for example. It's all a democracy. It's not about my ego. It's about what yous want to get out of it. And the reason I want to set it up is, like I say, I speak with patients. So I get 10 minutes, 10 to 15 minutes, depending on which clinic I'm doing, to speak with a patient. And when I go on in and I have a look at what consultations they've had, it's usually not that in depth. They come away with so many answers, or so many questions, sorry, not many answers. And then when I speak to some patients, if I've set aside 30 minutes, they will be on the phone for 30, 45. They will try and take up as much as time that I have as possible. So I thought, well, if I can give people more and more information, like doing these live streams, giving people the raw information, because at the end of the day, a lot of people think that people in the healthcare industry are led by pharma or by other financial incentives. I am not backed by anyone. For me, telling you to have a B12 supplement or to not have it doesn't change how much I get paid. So I think everyone should be best informed about their health, make decisions about it, and have the tools there, because at the end of the day, I don't feel like we as health professionals should have full control of your health. We should give you the information and you should be able to decipher what it is. So that is my plan with the live stream. Daily posts, weekly live stream led by yous, and then I will still be doing stuff on YouTube, but it will more likely be a pre-recorded video. Not scripted, but just very concise of a topic that I've picked. And if I've got time, I will always jump on and do a live stream, because it's always a good skill to learn. Like, I never thought I would be sitting here doing this in my free time, so it's quite good. Haven't told you about the diet plan. So yes, I will be doing a diet plan. I will do an example. I will put it on there for free. Again, see if it's something that you like. I think the aesthetic I'm going for is I'm going to take a photo of my morning breakfast. I'm going to put it as their breakfast, so you can sort of visualize it. And then from that breakfast, I'm going to do off like how much protein, how much, I don't know, B12, how much of zinc, whatever it is, and show you how I've built that plate, how you should go about building that plate, how should this be adapted to you. So for me, 30 grams is enough of protein in the morning. For someone else, it's only 20, and it will just all be giving you the tools to then go away and hopefully improve your health. Because, like I said, it is not rocket science. The internet makes it look like it's rocket science when in reality it is just the basics. If you do stuff consistently over enough time, you will get such a good return for your health. And that is one thing I want people to understand. I appreciate your live stream so much. I'm from the US, as you may already know. Thank you very much. The US, the one thing I found about the US, by the way, is that a lot more people within the US are more engaged in the health because of the private healthcare. And that is one difference that I notice when I speak to someone who's a patient from the US as opposed to the UK, is that they have a lot more idea around medication and certain procedures and diagnoses than someone from the UK. And that's because, if I'm being honest, a lot of people in the UK feel as though they are entitled because we obviously provide healthcare for free and you get access to, there are, even though the NHS gets a lot of stick, and I am one of the people who also calls it out when it should be called out, the professionals within there, there are some really high functional professionals and people get access to them for nothing. And sometimes people get access to them on a multiple level or frequency. So I have certain patients that I speak to multiple times a week where if it was in the US or I was doing it through other private sources, then they would be paying a lot of money. Sadly, I don't I don't get the benefits of providing any extra service to them. So I enjoy doing these things. I've learned a lot since I've started doing social media and doing an online platform because when I come out of university, you do 4 years as a degree, you do 1 year within a hospital. So I done in a cardiology hospital, and then I've worked in every sector in pharmacy. I've worked from drug making to in the community where you give out medication with the community. I've then worked in the hospital for so many years, specialist centres, and now within GP surgeries. And when you come out, you pardon me, as you've probably seen from this chat, there's something called NICE guidelines, which stands for the National Institute of Clinical and Excellence, which is basically a group, a governing, it's not a governing body, it's a group of evidence where if you've got a condition, B12 deficiency, for example, we will go to their guidelines and they will say, based on cost and evidence, this is the best way to treat a patient, this is the best way to manage their levels. And we take it as face value. We trust it because it is meant to be peer reviewed, it is meant to have certain things in. But a couple of years ago, I went down the route of trying to open up a social media platform. I tried to open up a blood testing company, which I did successfully do in the end, which was very difficult. And anyone who's trying to open a blood testing company, it is not easy. I will tell you that because of legalities. However, when I started doing that and started to step outside of the medical bubble that I was in, I started to see the world for what it was and how medicine is highly political, how it isn't really affecting people's lives for the better. And that's why there's a lot of friction when you speak amongst other healthcare professionals because, and this is my own opinion, by the way, this doesn't represent any other bodies that I work for or work with. But we, I think the best way to treat to discuss the NHS and our system in the UK is that we merely keep people functioning, where, in my opinion, we should be trying to optimize everyone. There are a lot of theories for this. If we give everyone optimal health, then we would have a very, very old population where it then becomes a burden on the system because we are paying out pensions. There are so many different things to it, but yeah, I just feel I just didn't want to keep people taking over. And hospital was great when you're working in A&E and you're working on cardiology wards and you're seeing someone come in who's literally just had a heart attack near death, and you give them the right medication, you give them the right doses, and within a few days they are back to function, and then everything's as though nothing's happened. So I did enjoy that side of things because you got an end outcome. But when you work with patients on a general basis in primary care, it's called, so that's GP surgeries, you are seeing people who, pardon me, you are seeing people who are just chronically unwell. So they're not acutely unwell that they need to go to a healthcare setting like a hospital. But you think if you would have took certain levels of advice from me and other people that they could have a better outcome. And when you actually see how guidelines are made, how blood testing is advised, and the way that we shift our treatments over to pharmacotherapy is first, it just didn't sit right with me. And I've obviously looked into things into great detail. B12, I will be honest, I picked B12 today. B12 is probably my weakest subject. I just done it because it's a very popular thing. I could have improved it, if I'm being honest, from this live stream. But there's a lot of things that I have picked up, and that's why I always advise people before they go into a consultation with any healthcare professional, have a good idea of what you are discussing. Yes, I am not expecting you to go in there and you're speaking with a cardiology consultant and you're thinking, oh, well, I need to know what LPA is. I need to know what level this needs to be. No, just have a good idea that you also have autonomy over your health decisions. At the end of the day, it is up to you as a patient to decide what you do. You could come to me and I could say, take this, 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 do this, and you could go home and not do any of that. So it needs to align with you. And that's why my practice has changed greatly. And that's why my clinics have become busier, because I think a lot of patients are finding that I give them a lot more time and give them the real truth. Like, I am not bound by anyone. I am not making any money by giving them certain medications. I always advise, which is ironic to people, to not go on medication. So I'm a pharmacist. I prescribe medication. I've got family members on medication, and I believe, yes, you should be on medication in certain instances. However, there is a time and place and the way that we go about treating. So actually, I'll give you an example. No, I'll just have a quick sip of this because my throat is very dry. However, if you think of stomach acid, for example, so let's just do, this is off topic, but stomach acid. So you've got your food pipe here, your esophagus, and then you've got your stomach. Funny looking stomach. You have something here. It's a ring of muscle. Think of it like a bobble. And it is called the lower esophageal sphincter. Now, heartburn is when stomach acid from your stomach goes up into your esophagus, and because your esophagus is not protected by any mucus and it's not really resistant to stomach acid, you get heartburn and you get the uncomfortable symptoms of it. First thing a lot of people do is go for one of two things. You go for Gaviscon or a Rennie. The reason being is that when these come into the stomach, they basically dissolve, they neutralize the stomach acid, and think about it by lowering your levels to this here. Next line is to have a PPI. So that is omeprazole, lansoprazole, all the zoles you can think of. They stop the stomach acid being produced again, lowering your levels to there. That is what we do. That is probably one of the most common prescriptions that you will see. I think it's the top 5 prescribed drugs within the UK. So a lot of people do that. And how would you put it? You will get a good result because these medications are so powerful. These are so effective. Pardon me. So you get a result. So why would you change anything if you just got the result from there? However, I always say to patients, if I was doing a consultation, why have you got excessive stomach acid being produced? Is it because you have ate something that's irritated your stomach lining? Do you have a disorder where you are overproducing acid? So that is called Zollinger, I'm going to spell this now, Ellison syndrome. Or do you have a lot of abdominal weight here? So if you've got an increase in an abdominal mass, you decrease the tone of this, which allows it to back flow into the esophagus. Have you had certain medication which has irritated the stomach lining again? Do you smoke, which reduces the tone of that? Do you have a lot of fatty foods, which reduces the tone of that? Do you have a lot of ultra processed foods, which again reduces the tone of that? They're all the questions that I would be asking as opposed to going for these first. Or if you were in severe discomfort, yes, use that first, but then go back to this because there must be a reason as to why you've got excessive stomach acid. And that's how I approach medicine, is try and sort this out first, because if not, you're either going to just keep having the same repeating cycle here, or it is an underlying disorder that you are merely masking. So that is how I go about medicine, and I will always advise people to go about it in the same way. So let me see. Yes, I like that. They covers all main vitamins, minerals. Yes. Why doesn't Jess ever get in the video? She's incredibly knowledgeable. Yeah, so Jess, for anyone who doesn't know, is my wife. She's also a pharmacist. She has a great interest in women's health at the moment. So she's early 30s, Jess, but anyone who is a female here, she's big on trying to advise women how to best manage their menopause, because it really starts from the age of 25-ish for you to get the best outcomes from that. So I think we are going to do a few things where she comes in and does a few things on women's metabolic health, because it is different to men. We blanket treat the population. Like I said, a lot of studies are done on middle-aged men, and that is because we can't really do it on women who are pregnant. We can't do it on children. We can't do it on elderly people. So middle-aged men were the people, because they are usually classed as the lowest risk of all people to have anything happen to them. So yes, it's probably something I would include. And I did say in that online community that I am doing, we've agreed, me and Jess, before, that she will come on and do a few talks with me as like a bonus episode, if you want to put it in. But yeah, we'll be doing a few things like that. B12 is definitely your weakest subject, but you've done well, thank you. I wondered if I had B12 deficiency for a while, because I'm exhausted all the time. I think I'm just anemic though. Like I said before, James, if you are classed as tired all the time, go and get a full blood count, and that is thyroid, diabetes, your kidney, your liver, your vitamin B12, your folate, your vitamin D. It does everything, because, like I said, being tired all the time, yes, more often than not, it is usually linked to some form of anemia. However, a lot of patients have an underactive thyroid, they have diabetes, which is not allowing them to use sugar properly, they have got an active infection, they've got so many things. So if you go and see a GP and say that you've got chronic fatigue, then they will trigger this thing called TATT, tired all the time. And that's the best way I would go about it. The fact you admitted your B12 knowledge is not the best shows you're an honest person. Thank you. My specialty is cardiology and lipidology, and I would say diabetes. They're the three things. Do I know about other things? Yes, I could go into a lot of detail in nephrology, neurology. I spent 6 months on a specialist neurology ward, so I've got a lot of experience, but there are things that I just have more interest and comfort in speaking. Broke out the matrix. So, no, free healthcare should be a right. NHS is, and that's absolutely dying to go to the hospital. Yeah, so at the moment a member of the family is in hospital, and they were in there for, I'm not going to disclose too much, but anyway, they were in there for a certain thing, and me, my wife, and her mum are all pharmacists, so we're all prescribers, we all do clinics every day, and the management that was put forward for this patient, a member of our family, I said, oh, have they done this, 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 this? None to all of them. And the patient was in for, they're still in now, I think it's like 3-4 days, and they've been given medication blindly and treatment blindly, and haven't been covered with the basics. And I always say I would always be scared to be a patient in the health service. It's okay now, because I know a lot of people that if I were to get sick, I could probably have a lot of good advice given to me or treated. But if I didn't know anything about healthcare, I would be very, very scared to go into a health system. And that is the truth. NHS should be private in the UK, because yeah, there's a lot of things with. So, do I do private consultations at all? I don't, in the sense that I can't act as a physician unless I've got a clinic. But in terms of on this community, I have put the option to have a one-on-one call, and the way I've done it is, or the way I've reframed it without it being a medical consultation and legally or illegal, is it's basically me going through the guidelines, the advice, the information in a way that you could format it yourself, and you could take away from that a lot of benefit. And that's the thing. So if you come in saying my vitamin D is very low, what do you think I should do? And I would say, well, actually, these are the levels that we would normally aim for. These are the sources of vitamin D. This is the normal treatment protocol. This is what I would be doing with high-end patients in my clinic. Then you can obviously take that away and you can apply it to your lifestyle very easily. And you can then have a roadmap to go to your doctor and say, well, actually, I want this test doing, I want this treatment. And you've got the evidence and I'll give the studies. So that's the whole premise behind it. So people take up doctor. Yeah, but the NHS being private, it will go private one day. It nearly did collapse in 2020 through COVID. I'll go through a couple of these questions and I will obviously call it a day because I didn't know how long I was on for. So thanks for being on here. But yeah, I've always said the NHS will go private. Whether when it does go private that you get the same level of care but you're paying for it, I don't know. I honestly don't know. I've always thought you should do more of like a pay-as-you-go scheme. So it's not private, but you should make a voluntary, like a voluntary excess. When you have a car insurance claim, you pay £250 regardless of the level of damage. And I think to have it as some form of barrier, it should be maybe like £10, where a lot of people will have access to £10, whether that be on benefits or certain things. And it just removes that ability of some people going, well, I probably shouldn't go the A&E because there's all these campaigns to say if you have a sore throat, maybe do this first before going to A&E and taking up precious time where someone's got a clot on a lung and they could be dead in the next 30 minutes. So it is a possibility. You and Jess would be amazing, Gio. Yes, thank you very much. I've coming up with doctor's appointment for blood work. That's why I'm asking. Yeah, like I said, if you I was saying this to a couple of people on the live the other day in terms of medical legal stuff, because to give out medical advice, you need to be acting within a clinic. You need to be acting under a certain level of clinical liability or indemnity. Sorry. So in my clinics, I've got my own personal insurance, and I've also got the clinic's insurance on top of me, and that covers me to prescribe it. Does a lot of other things, so I'm covered there. When you're outside of that, the only way around it would be to do things like this, where I'm doing it for informational purposes only. So if someone were to discuss blood results, I could do it hypothetically. So if someone wanted to give, oh, this is my vitamin D level, it was 45, I could say, well, hypothetically, I would like all my patients to be a level of 100 to 125 because this is the evidence here to show that you have greater functioning of your liver, kidney, whatever it may be. You've got greater muscle performance at this level. You have a reduced likelihood of having low phosphates. I don't know. But I would go about it in a hypothetical manner. I can't physically say, and this will be a lot of people if you watch them online, they can't say to do this and have this done because unless you are hosting a private clinic. But if that is something where you are interested, if you go onto WAP, I do have the ability to have one-on-one calls, and I will always give the information as clear cut as I can. So what's this one? So what is neurology? So when I worked in neurology, it was in the Walton Centre within Liverpool. So you've got different types of neurology. So you've got the clinical types where it's epilepsy, you have brain tumors, so like glioblastomas, gliomas. That is where neurology basically is. And technically, you've got Parkinson's a part of that, where you have certain Parkinson's clinics. And then you had neurosurgery, which was a lot of people who had cauda equina or cauda equina. I can never say that. Either way, cauda equina, so compression of all your lower nerves. You could have people who've got severe sciatica. You could have people who have cervical neuralgia, so around your neck, and basically you can perform surgery within 24 to 48 hours where you remove parts of the spinal cord, you basically shave it away, removes the compression, and basically within a couple of days people are up and out from spinal surgery. So I did, and obviously strokes, hemorrhagic strokes where you've got bleeds on the brain, subarachnoid hemorrhages. So I think I did 4 months on like the stroke ward, subarachnoid hemorrhages. I done 3 to 6 months on neurosurgery, and I done 3 months in the core clinical neurology, which was epilepsy. So it was a good experience. I'd love to see a women's health stream, so that'd be interesting to watch. If that is, like I said, it's going to be on that community. It's not a month. It's not a certain subscription fee. So it's £50 a month is what I'm charging, but it's not where you need to lock in for 3 months. So if you are looking into it and you go, oh, well, actually, there's going to be a women's health one on this date. I will also post it in the YouTube thing. So I might say this month we have potentially the following coming up in addition to the live streams, and it will be a women's health one with HRT, or it could be, there's a lot of things that she's looking into, and it's basically how can you best set yourself up for a healthy menopause, because a lot of patients that we see just aren't set up for it, and it does reduce the quality of life greatly. So it's something I'm more interested in. There's a lot of things I've learned by doing it, and definitely change my practice going forward. What is the subject you're most knowledgeable on if you had to pick one? I would say maybe lipidology, I would say, but cardiology is the one that I've always liked. I've always liked the fact that it's quite schematic and logical, so I've always liked cardiology. With the state of the NHS, I'm sure people would be down to take hypothetical medical advice. Thank you. Yeah, so for example, I've got my clinics tomorrow. I've got two within Manchester, two different types of clinics. They're not too bad. And then the one on Wednesday is in Cheshire. So if you're not from the UK, sort of a couple of miles out, 10 miles away from Liverpool, in between Liverpool and Manchester. And most of my clinics in Cheshire are fully booked up with people. Usually it'll be 30 minutes of consultation, which shouldn't be, but it normally is. And we go through absolutely everything and make sure everything's covered. So yeah, some of them can be good and are rewarding when you work with people who want to have a good outcome. The only issue that I have with working with the NHS, and this is why a lot of people tend to leave the NHS, one, the cover that you get for you don't really get paid enough to for the level of cover that you have. So if I make a mistake, for example, I prescribe something and someone has a bleed, let's say, and it was due to my clinical, I don't want to say negligence, but if it was down to me not being clinically correct, then I could appear in a court of law, which is never a nice thing to ever have over you anyway for the amount of money. If you were getting a lot of money, then you could sort of be like, okay, well, I'm sort of used to this level of pressure. And the other thing is that a lot of the patients who come into the NHS don't really want to be helped. And that is the truth of the matter. They just literally want you to come in, take these and get out. So a lot of people on social media say every time you go to the doctors, they want to give you medication. My stance, if you ever watch any of my consultations, is can we do exercise? Can we do diet? Can we do other things first? And the large majority of them are literally just saying to me, give me medication. And for me, it's then quite hard because if I don't give that medication, there's a good chance a certain bad outcome can happen. So I've got to give it, sadly, in some instances. That's good. I'd love to be a member if you provide a membership. I do. So it will be the 29th of May and it'll be on WAP. So if I do actually post quite a bit, if you ever go onto my YouTube channel, there's the community tab or the posts tab. If you ever go in there, then you can always look and I will put up a lot of things. What is lipidology? How are you getting there? You don't have your Tesla anymore. So lipidology is the study of lipids. So that is anything to do with atherosclerosis. So they are when you get a cholesterol profile. That's something I've had a big interest in just because there's always the ambiguity. Should you have high cholesterol? Should you have low cholesterol? What does it all mean on a higher level? Because when you're in university and you're in medical, like training and all them things, you don't really get told too much. You get told very little. So it's only from us doing extensive research and looking into things with credibility that we've gained a lot of experience in that. So that's what lipidology is. Anything with ology on the end is the study of. So that's how it comes from the Latin, I think. And then lipids, obviously, so the study of lipids, biology, the study of the body, or things, so you can sort of get the gist. How are you getting there? So all my clinics are remote. So I'm used to doing remote clinics anyway. I did have one time where I was going to do in-person clinics because I did do a specialist thing within high blood pressure, so hypertension. However, I didn't end up organising the clinics, and I think maybe over the next few months, I might, depending on where my work goes, I might do the odd blood pressure clinic because it just gives you experience doing the manual blood pressure readings and going through how to manage a patient. I normally do that virtually though. I've had quite a lot of patients recently who've had poor blood pressure, and I've just sort of started watching, if I were to treat them with this, how much does it go down by? And it's amazing how much you can affect someone's blood pressure by just giving one medication within a short period of time. Right, I think I will give it a couple of more minutes and then I will be going. Sure, just because I said to someone that I would be on this for maybe half an hour, and 84 minutes later, I'm still on, which normally happens. So I appreciate everyone who's commented, asked any questions, and obviously watched it this far. Hopefully, some people do get some benefit from it. So, is there something you're not sure? So, to be honest, with the level of clinical questions that you get, there's not many things that I don't want to say this where it comes across big-headed because it's not meant to, but the level of questions that you get, normally you can figure out yourself. But if there are things that are a bit ambiguous, then yeah, fire away, ask a question, and then I'll call it a day after that one. But if there's anything where I'm not really too sure, you can obviously ask your peers. So I might ask another GP. I may ask obviously Jess or any other people that I know who are pharmacists and see what they would do. But normally we've had that much experience and that we sort of have a good idea to a lot of things, to be honest. And the hardest thing for me was in a hospital, when you do something where you change a medication or you change a treatment, you have access to blood testing observations instantly. Whereas when you work remotely and you do it through a GP surgery and you are changing someone's treatment, you can potentially, you've got like a delayed reaction. So you may not know their blood test for 2 weeks and you just give them something which can potentially affect their kidney if they are one of them people. That was the hardest thing for me, is not having the data 24/7, and it's something that you learn to grow with experience. And yeah, it's something that I have learned. So that was a big change coming from a hospital. But yeah, if you've got one last question, fire away. And then after Pink Fairs asked it, okay, that's very entitled behavior to just, yeah. And like I said, I always go for lifestyle first. Always a big thing for lifestyle. So, but then you always are faced with this dilemma, is that if you know a patient's not going to follow. So let's say, oh, I can't even think. If someone's a severe alcoholic, for example, you can slowly come off the alcohol, give them a proper diet, make sure that they're not deficient in vitamin B1, which is a big thing because it can lead on to Wernicke's encephalopathy. So there's a lot of things that can happen there. But in some patients, you know that they're not going to be able to do that. So then there is a medical protocol called Librium where you can basically give that to them and it aids the detoxification process. And then it comes up with anything in medicine and treatment is a risk benefit. So is the risk of me not giving something because it's a medication or it doesn't align with certain values going to outweigh the risks of them not doing something? And that's basically what healthcare is in a nutshell, is just weighing up. Some things may always come up with a bad outcome. So think of cancer, chemotherapy, and radiotherapy. Both of them are, well, radiotherapy and not treating the cancer. So not treating the cancer can lead to death quite quite soon, depending on the progression level. But if you give radiotherapy, you are destroying a lot of the body's healthy cells, and you can lead to a lot of side effects. So basically, you're weighing up, is living with a loss of function better than not living at all, and that's basically it, really. So what's the next live and video about? So the next live and video, I will probably do a next live, maybe try and do a live next week. Again, Monday. If not, it will be a video. But again, I'll post it in the community tab. And the last question is, I have constantly been having low white blood cells. Said I'm fine. It's a condition normal with people from the Mediterranean area. With low white blood cells, so white blood cells are usually made within the bone marrow. So first things that come to mind are, have you had any damage to your bone marrow? Do you have anything? And I don't want this to come across as scary, but you need to check whether there's anything going on with your bone marrow. Obviously, very, very poor, complicated, or circumstances are leukemias. I'm not saying you've got that, but they're the things that you need to look at. If you've got low white cell counts as well, is it because the body is destroying it within the body, or is it a lack of formation? Are you getting increased infections? Because yes, let's say it's normal from the Mediterranean. I mean, let me have a quick look because I don't really get too many Mediterranean patients. So let's see, Mediterranean, low white cell. Let me see. So let me have a quick look here. So benign ethnic neutropenia. So some people of Middle Eastern descent naturally have lower neutrophil counts. The biggest thing is with any of these conditions is making sure that it's being looked at. So with the low white cell counts, there is a potential that the Mediterranean diet, as we all know, is the gold standard for low levels of inflammation. If you've got low levels of inflammation, you will have lower white cell counts. Having a higher white cell count is not always good because it means that there's obviously something there that's trying to be fought off by the body. But I'm just trying to think of the other thing. So you've got to look at white cells and neutrophils at the same time, and you need to make sure that they are not chronically low, because if they are, you are more susceptible to infections. And that's what they told me, benign neutropenia. Benign hematology is very complicated, by the way, as you've probably learned through going through how one blood test could be high and one could be low. There's so many complexities with it, but if I'm being honest, I probably wouldn't give you the best answer that would probably calm you down, because hematology is so complex. But I would probably take from it the fact that the diet is usually low in inflammatory molecules, so you will have a lower white cell count in comparison to a normal population. You then need to look at the fact that is it low in relation to your population, or is it low objectively? Because if you live in an area where people have high levels of white cell counts, there's a good chance that your level will be calibrated alongside theirs. And if you're low with an unhealthy population, then you may not be low. It's just that everyone else is not doing that well. The thing is, as long as you've been seen, that is a good thing. But things to look out for, if they're saying it's okay, I would obviously trust hematology because they have a wealth of experience and see this more than I do. I very rarely see low white cell counts. The only time I ever did is within cancer wards. But the things I would look out for are increased infections, increased tiredness, if you have increased levels of bruising, because yes, they're not directly related to the white cells, but that could also lead to the fact that your bone marrow isn't producing enough hematic, or what is it called? Hematopoietic stem cells and all them things, so your platelets will be low. They're the things I would look out for, but definitely it is out of my remit, and I wouldn't give you a full in-depth answer apart from as long as you are being looked at by hematology and you are not showing signs of tiredness, infection, and you haven't got a family history of any leukemias, then I would merely try and get it assessed every 6 months until you have a stable trend. That is a big thing. Medicine is all about trends. You could have a low level there, but how long is it being low for? If it's the same level for the next 24 months, and you get it checked every 6 months, then there's a good chance that that's your baseline. And that's why we've got to treat the person, not the level, in a lot of circumstances. But yeah, look, see, like that is an example of what would I do if that was a patient of mine. Normally, they would have been seen by hematology, and if they hadn't, I would be writing for advice and guidance from hematology. That is what I would be doing and checking in with the patient. So that's the way I would go about it, because that is why you have clinical specialities. No one can know everything, but you need to know safety cutoffs and you need to know when someone should be referred. Same level every time. So that's obviously more comforting It's just that I would always make sure that it is being repeated all the time. Try and get access to it every 6 months. Yes, it's a pain to get your blood checked, but it's always beneficial to know where your levels are. And if you can get an opinion from hematology, which you can in the UK, you can just normally ask your doctor to send a request through. If they get an opinion on it, then it's just even more comforting for you, which is a big thing in healthcare. Yes, you may be fine and it may be good on paper, but until you know where you are at, then yeah, it can create a lot of anxiety. Helpful and important. I appreciate it truly. Take it easy. Enjoy what's left of the day, brother. Yes, thank you very much. And I'm gonna go up now and get ready for tomorrow, which is just a normal working week. Stay if you are interested, have a look on the post on the community tab. I normally post on there daily and try and update you where I'm up to. And I will see you hopefully on the next live stream. I'll probably do one more next week and then it will go to videos. But again, I can discuss that on the next live. And I will go through a topic that hopefully people are more interested in and I can give a bit more information about. I have to say it all the time. It wasn't medical advice. It's all informational purposes only. And hopefully it sparked a bit of debate and made you look into something and just probably taking away the mask that's normally present on a lot of things that's given out by the health system. So have a good evening and I will see you soon.